Yes. It's just a general comment, a general question to all three of our panelists. See, what I can see that somehow the attendance today is a little less than our regular webinars. Maybe it is a niche topic which can interest only a few of the people. So my question is the learning curve of foot and ankle arthroscopy really long? Because I also do a little bit of ankle arthroscopy, never has tried for an ankle. And today, this webinar has given me incentive. I was thinking for a long time, but now it has given me incentive to, go into that field and start learning. So for somebody who has not yet done an arthroscopy, how would you say, the three panelists, my question is to all three panelists, how tough it is or how hard it is or how easy it is to get into this thing?
Shall I start?
Yeah.
Yeah. So when people started shoulder arthroscopy, previously people used to say that you should have done a knee arthroscopy before you proceed for a shoulder arthroscopy. So that was the thought for most of the surgeons' mind. Then when people started doing only shoulder arthroscopy without doing knee, like they become a shoulder surgeon, then they didn't have any difficulty at all, because just they went for some fellowships, they did a 2-3 cadaveric courses. Just what you need is in the hands and your coordination, hands-eye coordination, your triangulation technique. So that is applicable for all the joints. Of course, ankle is one of the easiest joint to go inside, and even though the space is very tight, but once you know the anatomy, arthroscopic anatomy very well, it is not very difficult, because if the space is very limited, your structures are very less compared to the shoulder. Still, it is easier than shoulder or a knee, in my opinion. When you want to do an ankle arthroscopy, it is not very difficult. If the beginners wants to do an ankle arthroscopy, I would recommend to go and see some surgeons who does ankle arthroscopy, few. Then you go to the cadaveric course, at least do a 2 cadaveric course, then you get the confidence, then you'll be able to do that. You don't need to be a knee or arthroscopic, shoulder surgeon.
Excellent points there, I think. Dr. Simon, you want to add on to that? You're muted. We can't hear you. Yeah.
Sorry, the Arthroscopic Society's big man has spoken, so I don't think we have to add on further. I think the point is well said by Sundar, so I don't think we need to add on further on that.
Yeah, and Kushal?
Yeah, I guess, I've never done a shoulder arthroscopy. Maybe a couple of knee scopes long back. But it's a learned skill, right? Even the first time I did it, I struggled, right? My fellowship days, it was under the guidance of your boss. It's easy, he's holding your hand. But when you come back and start doing it, you realize the first time I did my, arthrobostom 5 years ago, it took me maybe 1 hour, 1.5 hours to find the fibula, right? Where is
absolutely.
it? So now it takes me approximately 45 minutes to complete the whole procedure. So it's a learned skill. The best way, I think, is to, when I started, I had some friends in medical colleges, right? And I told them, why don't you have scopies? If you have ankle problems, ankle issues, why call me? I'll do a scopy there, I'll show you guys. You guys also can learn. So I did my initial few cases in the medical colleges with my colleagues who were lecturers or, faculty there. So that helped me, get a bit of confidence. And then you go into your private practice and then you still struggle, but you eventually get better with time. So, you have to dive, right? If you don't dive, you won't know to swim.
So now what you need, all of you, what you need to do is to train more fellows under you, isn't it? So that more people get those skills and pass it on further down the generation. I think that's a great point. One question that comes to mind is, how do you recognize the ATFL arthroscopically? Is there any specific area,
Yeah, so
wants to take that?
If you go in and if you look at the lateral gutter, now you'll see those white fibers coming down, from superior, anterior, superior to inferior. You'll see those white shiny fibers coming down. It will be behind the muck, it will be behind the fat, behind those, white pieces of fibrous tissues, the synovium. Once you shape those out, you will see those smooth fibers coming down. So that is the ATFL, right? And so when you put in your lasso to, to take out it punctures through the remnants, through the extensor retinoculum. It basically, my boss used to call it a face, it's an ankle lift, just like a facelift, right? It's an ankle lift. So what that it does, it actually draws the, the soft tissues into the fibula and sort of tightens the ankle. It is less tight than a fiber tape, but I find that that tightness is something which patients like. If you make it too tight, a few of my patients who had open procedure initially, right, and they sometimes complain कि मेरा ये ankle थोड़ा सा is less free. Maybe I over tightened it with a fiber tape or something. Maybe.
Yeah. Sundar, do you want to?
Yeah. I mean, I was also doing open procedure for quite long time. Maybe after the lockdown, maybe I don't know what to do. So I started doing now arthroscopic procedures. I use mostly all knotless anchors. I use a two push lock anchors. One of the easy identification, I mean, for ATFL is, the first lateral, when you go into the joint, when you see on the lateral side, what is the striking structure is your AATFL, inferior tibial ligament. You just follow the ligament. And you go distally, then you go and see the insertion of the fibula. From there, you down, what you see in the anterolateral surface of the fibula is your ATFL. But over then you track down to the dome of the talus on the lateral gutter, you will see the nice incision. But most of the time, it will be overlapped with all the fatty tissues. Sometimes you will have a fibrosis and capsule. So you need to, as Kushal shown, you have to clear all the soft tissues to see the ligament. But you surprised to see sometime after the clearing all the tissues nowadays, I was happy. Why the hell I didn't do, being an arthroscopy surgeon, why the hell I didn't do arthroscopic procedures for quite a long time. It is so easy and find a nice structure of your ATFL once you track down from that incision level. So it is very easy.
Absolutely right. And I think one of the common mistakes initially is that you take off the ATFL as well along with the fibrous tissue. And when you start seeing muscle, then you are slightly more deeper than what you thought. So I think that's great. Yeah, Sundar. So one more thing, does Dr. Rajesh, you talked about an injection for impingement. Do you do those injections routinely before you do an arthroscopy, or do you do that in only certain patients?
Yeah, my indications are when I'm myself confused. When ATFL, CFL with the instability, MRI is there to say that, okay, then you have all the clinical symptoms of instability. You don't need anything of injections. This is when you don't know what is the problem. The problem is something different and the MRI finding is different. Then, or especially, as a foot and ankle surgeon, especially in the midfoot, you do not know which area is a problem. That is where we actually go for injections. And I always do under CIAM guidance. So don't inject too much, just a little bit, just to diagnose. Helps me in many a times. And that is one clinching way when I did that girl's injection, just 1 ml injection into that, and she was perfectly fine. And that convinced me as well as the patient's mother for the surgery. So otherwise I wouldn't have operated. Now I would like to ask a question about both Kushal as well as Sundar when they're doing arthroscopic rostrum. If you have a football player here in Kerala, we have a lot of football players with ATFL and CFL injury. I would prefer to do a open rostrum with this fiber tape and extensor retinaculum, all to give me that security feeling. And it gives a pan correction, and it's not a point correction. You feel that it is really good. So if you get a very hardcore sports person, would you be happy to provide? Would you go and still with an arthroscopy because you say that is better off, or would you, in such type of a hardcore professional, would you give the traditional open rostrum?
Good question, Simon. But let me be a bit philosophical about this, right? What do a shoulder surgeon do? A cricketer or a baseball player with a cuff tear or a labral, whatever, bank card. What would they do? Would they do an open repair? I don't think so. Maybe an open repair would be a better procedure, right? I'm not saying open repair isn't a better procedure, but I would still talk to my patient and tell them that at the level that you play, injuries are a part of your life, right? And if you keep injuring yourself, this repair will again fail. So nothing is fail safe. It's not as if ki ek bar kar liya kabhi nahi hoga. So that message has to go through. If you are well trained, your ankle rehab is good, and in all likelihood don't get a bad injury, you will get away with it. But if your ankle rehab is poor and you have a bad injury, unfortunately, you can again rupture. And if that happens, then yes, I'll go back and do a open procedure as a revision sort of a thing. But I still like to go in as with arthroscopy as a primary procedure, like Rajesh has initially said. All of these guys also have a lot of other niggles. You know, they have osteophytes in the talus, osteophytes in the fibula, in the tibia, maybe a bit of impingement there. So I can do more of it with the same procedure. But yes, that caveat is always there. Once done doesn't mean it won't tear again. So that message has to be conveyed very clearly to your patient.
Yeah.
Sundar, your take, the recently converted arthroscopic ankle.
So far, I mean, last few, I mean, maybe the last 6 or 7 cases, I'm doing only arthroscopy. Of course, I mean, if the tissue quality is poor, I mean, if I feel that the tissue quality is poor, I don't hesitate to open to do any extra procedure like internal bracing or doing a good procedure by open, by where I can make more stitches than arthroscopically. But so far, what are the cases, I mean, I'm doing, I could see that ligaments are in good quality. So I have done only arthroscopy. I have not gone back to the open procedure, but I will not hesitate to do open procedure. As Kushal also said, there is a failed case, or sometimes if you have a very tissue poor quality, then it is you can do an open procedure. But as he said, another advantage is recently I did an Assam by football player. But he had a lot of loose body, he had an arthropfibrosis, he had an impingement. So he had all these findings. So it is easy to do all these 3 arthroscopic. I removed the loose body, removed the osteophyte to do a arthroblastrum. It was a very good procedure, very quick. We are not doing any periarticular damage. So I think the rehabilitation is going to be quicker. I think that's why I believe now to do an arthroscopy.
Thank you. Yeah. Rajesh, I think, do you have any comments on that, on those two? So,
yeah, I mean, when I do an open this thing, and when I have a doubt, so the advantage is doing all scopically. Otherwise, in such type of patients, you do scopy, do your impingement removal, everything, and then go back open. For me, my doubt was always on a sports person, on a hardcore sports person. So here we do get Kerala. Kerala is like Bengal. We have the football crazy fans, and we do get a lot of Omanis coming up. The same footballers having crazy things. So that is where I am like little this thing about open versus arthroscopy.
So open, you would open you would want to do basically to put in an internal brace. Is that the reason, or
maybe yes? Internal brace gives me an additional feel-good factor, because these Omanis are quite crazy guys, and they don't really follow up the rehab the way we explain. Maybe that is why. Maybe I have a bias, but yes, that is.
But eventually, if you were to be able to put in the internal brace arthroscopically, which you will, if you want to do it, I think that is also possible, to sort of do that as well. And I think one of the indications which I think I do it, tend to do more open or internal brace is when the patient is hyperlax. A patient who's hyperlax, who's likely to just stretch out his tissues over time, maybe over 6 months, then I think an internal brace addition, and then maybe an open at that time. So, Dr. Rajesh, bilkul absolutely right that, I also tend to do an open internal brace. I don't do an arthroscopic, but eventually as we learn more, we'll be able to do it arthroscopically, and even that indication of open will gradually fade away. So I think it's a learning curve. I think that's what we've learned today. Anything else anybody wants to comment on this?
Kushal wanted to say something, I guess. He was
Kushal, please.
trying to say something. Kushal?
You are muted, Kushal.
Yeah, so I think what we should do in a way is to focus on the rehab a bit more, right? I mean, before I ask my patients to go for a surgery, I give them 1 month of rehab, and I have this couple of physios who I know, and I know they will do a good job. I send them home, ask them to do it. So, there's a feedback loop for me. I know that guy is cooperating, that guy understands pre-op as well as post-op, and he understands the gravity of the situation, that surgery is not the only, panacea for your problem. You also have to contribute to make this a success. So if you can get good physios who know how to train about ankle strengthening, ankle proprioception, and all of the stuff, I think it will help me sleep better at night. Let me put it that way. But coming to Maninder's point, he's absolutely right. If you have a patient who has lax joints, lax other ankle, lax other joints, then I think you're better off doing a fiber tape. No doubt about that.
Okay, great. And one more point which I would like to stress upon is sort of Kushal said that he puts his rostrum repairs, arthroscopic rostrum repairs in eversion when he's tightening. Is that the same with you, Sundar and Rajesh? Is that sort of Simon? Do you do that same as well?
Sorry, what is the question, Maninder?
Sorry. So do you put your, when you tighten your rostrum's repair, do you put your ankle in eversion?
Yes,
while tightening?
Yes, I do, but because I'm doing now knotless, but I make sure that I have enough slack of the fiber wire or the fiber tape which I use, so that I don't do a over tightening. Because when you use a knotless, sometimes you don't have a control how much you are going to pull the ligament to the bone. So usually I'll have enough slack, but still I keep it in eversion. So, but I don't tighten too much.
Okay.
Same.
Yeah.
Eversion.
Okay. Great. So slight eversion. If you were putting an internal brace, would that be any different? Would you still put an eversion?
No, we don't. I mean, we don't put in too much eversion there because you don't want to tighten the joint. Really, we don't put too much eversion. Like what you do in open procedure, where you do the keep an eversion when you do tighten the knots. But in do internal bracing, you have to be very careful that you are not too much tightening the joint, because that
Fiber tape is always with a pinch of salt. I take it. I use it only when indicated, especially on a high demand sports. Yeah. Otherwise, for me, and the Brostrom Gold has worked really good without fiber tapes. Yes, for a very high demand, I use it. But having said that, I have had a very bad experience with fiber tape. One of my patients went on having a huge amount of scarring. And when I went back, I just could, he had this huge amount of blackish tissue coming out of that area. So that is one thing which you should all remember. There are problems. It is not about the laxity or it's just that the patient did not react well. And there was a lot of allergic reaction or what, I don't know, it was blackish tissue over the fiber.
I think you're right. The internal brace has been shown that if it is bathed in synovial fluid, then it doesn't do that well. Sometimes people get allergic reaction, especially if it is extra articular. Then basically, if it's not reacting with synovial fluid, then usually does okay. But if it's bathed in synovial fluid, sometimes like we do the ACL and stuff, it's been shown that it's sort of it's not that. Sometimes some patients can have a problem with the internal brace, especially I think the R6 one. So I think that's great. If there's no other question, I think nothing in the chat anymore. If I think we have Dr. Shantanu, do you want to? I think we've had a very interesting discussion today. Anybody else wants to make any remarks on any of the topics? Any of the panelists, they want to say anything more?
Right. Yes. I guess before we close, there are certain things that I need to put it here. That thank you so much, IFAS. We are having a great response. Although not many people are able to watch live because they have many engagements on the Sunday evening, but we are having great audience who come back and watch our videos in YouTube channel, in our IFAS YouTube channel. We have a great plethora of subjects like orthotics in foot and ankle, like diabetic foot, like ligamentous injuries in foot and ankle. Quite a big list of webinars are coming up in the coming Sundays. So my request to all my members is to log on to them and encourage us to bring the best to you. Second thing is IFASCon 2021, which is going to be in Kolkata. The IFASCon 2021 team headed by Dr. Abhijit Bandyopadhyay. They are leaving no stone unturned in making this a great event. A lot of foreign faculties are there. Some are going to be, most of them are going to be there physically. and many will be there virtually. This probably is the time when we can come together and register in maximum number to make this a huge success. So my appeal to all of you, to all my listeners, is to make AFASCON 2021 a huge success. Yeah, over to you, Maninder.
Okay, great. I think we'll finish off now. Thank you everybody for joining in. Dr. Ajoy, I just noticed you were there as well, so thank you for joining in. If I had known earlier, I would have taken you in the discussion as well. So I would thank all the panelists, Dr. Sundar, Dr. Rajesh Simon, Dr. Kushal Nath, for joining and giving us such an interesting day of discussion today. I learned a lot today, and I'm sure all of us who have participated and who will watch the YouTube video will learn a lot from this thing. So thank you all very much and for joining in. And we hope to have a much more similar experiences in the next webinars that we have. So encourage, as Dr. Shanu said, encourage everybody to join in on our webinars on the Sundays evening. Thank you.
Thank you so much, guys.
Thank you, IFAS.
Bye-bye.
Thank you, everybody.
Thanks. Bye.